Welcome to the first session, the first scientific session in this meeting, in this multi-brain meeting. This session has been focused in neurodevelopment in a sense that problems maybe during the development of brain can explain later some pathologies that are so common. So we are going to just start with Dr. Míriam Pérez Cruz. She's a specialist in fetal medicine at the BCNatal Fetal Medicine Research Center and is also a postdoctoral researcher in the Sant Joan de Déu Institut. She combines medical assistance with the study of the prenatal origin of adult disease, and during the last years, she has focused in neurodevelopment. Today, she's going to talk about recent research that focus in the use of neurosonography and brain electrophysiology in fetal neurodevelopment. Thank you, Míriam.
Good morning. First of all, thanks to the organization for this invitation. As Silvia said, I'm focused on the study of the neurosonography in fetuses from a clinical point of view and in a research point of view. So I'm obstetrician. I think that I'm the only obstetrician here, both with Dr. Gomez. I will try to make you enjoy as much as we enjoy with this specialty. We know that 1 out of 10 of children will develop any kind of neurodevelopment disorder during their life. And 2 out of 3 of them will have a prenatal origin, but only few of them will present an early diagnosis. And why is it happening? We can explain it with the example of the iceberg. Normally, those newborns that will have an early diagnosis of neurodevelopment impairment will be those that already presented alterations, severe alterations in the prenatal brain image, or that present severe symptoms after birth, like cerebral palsy or severe cognitive delay. But this only represents a very small part of the problem, because vast majority of cases will be unnoticed during prenatal life, because we'll have normal neuroimage by clinical tools, but we'll have subtle functional problems, like social, emotional, behavioral, motor, sensory, hyperactivity disorders, autism spectrum disorders. And with a simple vision, the brain connectivity is essential for the normal functioning of the brain. We can say that the software is the gray matter and the fibers is the white matter. And there are many conditions that during the pregnancy can have an effect in this development. Some of the most frequent conditions that could make changes in this brain are, for example, severe fetal anemia, or fetus with congenital heart defect, infections, prematurity, severe maternal pathology, growth restriction and preeclampsia, or to be born very big for the gestational age, or monochorionic twins. All these conditions can produce permanent changes in the brain. And then it appears the concept of fetal programming. How is the first moments of the life since the conception? Because fetal programming is a concept to describe how some conditions during the pregnancy, in very important moments of the pregnancy, may cause permanent changes in the fetus that will persist in the infancy long after birth and will explain part of the future health of this patient. And the impact of this environment is crucial during fetal life, in a lesser degree during childhood. And it gives us some windows opportunities to try to reverse these effects. So the first question is, how can we know what fetuses will present fetal programming, will present permanent changes that will explain some future alterations. There is a lot of research focused in this important aspect, but the first thing that we need to highlight is that the fetus is not an accessible patient. It's inside the belly of the mom, so we cannot explore the baby. We cannot take it to make a physical exploration and inside again. And the acquisition of image are also difficult for this reason. The MRI, the fetal MRI, it's very useful to explore the brain structures from a structural point of view, from a functional point of view. We can, again, study cortical regions, white matter fibers, but what happens? It's not an easy tool, it's not accessible, it's expensive. We cannot perform an MRI to all the fetuses that we expect that are in a high-risk conditions. And then, our best friend in obstetrician is fetal ultrasound. This is an excellent tool to have a depth and detailed evaluation of the brain structures. And it's easy, it's cheap, it's a cheap tool, and all the obstetrician can manage normally the ultrasound. And what's a neurosonography? The neurosonography is the deep exploration of the brain by ultrasound. And it's the best tool to diagnose malformations. But during the last years, many research have shown subtle central nervous system changes in high-risk conditions that could maybe be explaining part of this programming that we were talking about. We can perform neurosonography during all the pregnancy. We can evaluate brain structures in every gestational age. We only need to know very well how is developing the brain, how is the image in the neurosonography changing for every gestational age. Here you can see how we start a neurosonography by transabdominal ultrasound. This is an axial plane. And first, we have like a general view of all the axial all the structures that we can evaluate in the axial plane, and then we obtain like systematic planes to study specific structures. After having the axial plane, we will continue with the coronal evaluation. Let's see, the quality of the image is excellent. It's similar to the transfontanelar neurosonography that we can perform in a neonate after birth, but with the difference that the baby is inside the belly. Here, the coronal planes, and finally, sagittal planes. This is maybe the most important plane in the advanced neurosonography because we can explore very important structures, the corpus callosum, the vermis, the pons. For us, it's crucial and it gives us very important information. And is in this plane where we will focus today, where we are going to talk about brain structures in fetuses. Let's see, the corpus callosum can reflect the white matter and the brain connectivity, are like the fibers that are crossing. Because the corpus callosum, as you know, is the biggest white matter structure, is the most important interhemispheric commissure in the human brain that has an exponential growth until adolescence. And it's very important to see that it's an indicator of normal brain development and maturation. For us, for example, as obstetrician, when we are performing neurosonography in a high-risk fetus and we find a very beautiful corpus callosum, for us it's like, okay, relax, probably everything will be okay because it is giving us very important information. And after that, it's a biomarker of white matter loss, so it reflects brain connections. And the most important function is the interhemispheric function, as we were talking, because it connects different parts of the cortex. No? From anterior to posterior, we'll be connecting different parts of the cortex. So with this knowledge, our group has tried to study the corpus callosum in different high-risk conditions. And we will start, for example, with congenital heart defect. Congenital heart defect is the most frequent congenital malformation. Around 1% of all newborns will present any kind of congenital heart defect. Of course, not all will be major, but near 50% will be major congenital heart defect and will require surgery to correct the heart, maybe during the first days of life, during the first year of life. And the first challenge that as obstetricians we had in congenital heart disease was to decrease the mortality in this population. And we can say that we have overcome this challenge because the mortality nowadays is very low. You can see here the results that we have in Sant Joan de Déu. The mortality after surgery is very low. And here in this study, you see what's the distribution of the population that was born with congenital heart defect. It's estimated that in 2010 in USA, there were more than 2.5 million of patients that were born with congenital heart defect. And at the moment, 1.5 million of these patients are already in adult life and arriving to geriatric life. So it means that in the future, with the improvements in the surgery techniques, the prevalence of congenital heart defect in the population probably will increase. But the next challenge in this population it still remains, because above 25–50% of these babies born with congenital heart defect will present neurodevelopment disorders. It's sometimes will not be severe disorders, but yes, subtle disorders with an impact in the life. There are many factors that can explain these disorders, and all these are appearing consecutively and with synergia. And the fetal life has a relevant role, because how can we obtain a normal development of the brain with normal supply of oxygen and nutrients? And what's happening in congenital heart defect? If I have an alteration in the blood, in the vessels of the heart, I will have an impairment in the oxygen and the nutrients that will arrive to the brain. The circulation is changed in these babies. And this hypothesis is reinforced by the evidence that those congenital heart defects that have a most important impairment in the oxygen in the brain have a most important impairment in the growth of the brain. If we compare with those fetuses that maybe have a congenital heart defect, but that maintains a near normal concentration of oxygen to the brain. And the most important pattern of brain damage in newborns with congenital heart defect is the white matter injury. A very high proportion of these newborns will have a moderate or a mild affectation of the white matter. And it's clear that newborns with congenital heart defect will present white matter maturation delay. Neonatologists always say that a newborn with congenital heart defect at term, around 39 weeks of pregnancy, has an immature brain that we can compare with a premature baby that maybe was born at 34 or 35 weeks of pregnancy. And probably the explanation is that the chronic hypoxia will alter the maturation in the third trimester of the pre-oligodendrocyte to mature oligodendrocyte. And again, the paper of the corpus callosum to study this white matter. We designed this study in order to evaluate if fetuses with congenital heart defect presented a smaller corpus callosum, and we included 56 isolated severe congenital heart defect. Isolated is a concept that is very important in obstetrician. It means that it has no extracardiac abnormality and no genetic abnormalities that we can identify by RI. And in all them, we performed the neurosonography around 32 weeks of pregnancy. Remember that the pregnancy normally finishes around 40 weeks, okay? So take the point of view of 32 weeks of pregnancy. We measure the total length, the total area of the corpus callosum, and the subareas after division by Whittleson classification. And we stratify congenital heart defect into functional classes depending on the expected oxygen that was going to arrive to the brain. So there were like more cyanotic congenital heart defect and another group of congenital heart defect with nearly normal expected pattern of oxygen arriving to the brain. And in general, fetuses with congenital heart defect presented smaller corpus callosum when we compare with controls. And there was a linear tendency across the groups. So those fetuses that were classified in class A because the oxygen that was expected was lower presented smaller corpus callosum. And in general, the most affected part of the corpus callosum was all the posterior part, because we know that this is the part of the corpus callosum that is growing during the 3rd trimester. So we consider that the corpus callosum could be a biomarker of neurodevelopment in congenital heart defect. And what about this? This was a bichorionic biamniotic twins that were born at term at 38 weeks of pregnancy. They are sisters, but Berta seems that she has difficulties to take out the key from the bottle, and Laia achieves very fast. So do you think that maybe there is any fact, any explanation for these differences between them? Berta was born with a very low birth weight, less than 2 kilos. She had placenta insufficiency, while Laia had a normal weight, more than 3 kilos, with a normal placental function. And what's the effect of the fetal growth in neurodevelopment? Normally, in normal pregnancies, fetuses are growing correctly inside the belly of the mom. And the placenta has a very important function because it's the one that connects the mom with the fetus and allows the transfer of oxygen, nutrients, proteins, all the elements that are relevant for a normal development. When we have a fetal growth restriction, what happens is that the primary process of the placentation, it means the process when the tissue of the placenta makes the invasion of the wall of the utero. When this process is not correct, the surface of the active placenta is smaller than expected. So the capacity of this placenta to transport oxygen, nutrients, etc., will be decreased. And what's the answer of the fetus? We'll start to decrease the velocity of growth, so we will find that the weight is smaller than expected. And this chronic situation will have an impairment in key organs as heart and brain. We define fetal growth restriction or intrauterine growth restriction or small for gestational age, or these are synonyms, as those babies that are born with a birth below the 10th centile. So by definition, it will affect 10% of births. That it's more than 500,000 of births per year in the world. And fetal growth restriction is a direct cause of 25% of special educational needs. They have lowest IQ score, increased risk of attention deficit or hyperactivity disorders, and negative impact in social function. And if we evaluate the impact in normal life, we see that the proportion of patients that will have an unskilled job will be the double in those that were born with low weight. And as well, the entrance in the higher school will be later, and the proportion of the learning difficulties will be higher in this group. But we don't need to wait until adolescence to see these effects. In the newborn or at 2 years of life, we already can see that they have lower punctuations in all the areas evaluated by neurodevelopment tests. So again, as obstetricians, we think, can we detect these babies? What babies are going to present these problems? And again, for this presentation, we talk about the corpus callosum. We evaluated again the corpus callosum, and let's see Berta. Berta couldn't take the key from the bottle. She had a shorter corpus callosum compared with her sister. And the area of the corpus callosum was also smaller in IUGR or in small babies. And again, as in congenital heart defect, the impairment was more severe in all the posterior part of the corpus callosum. And in this study, it presented a correlation of the decrease of the corpus callosum with neurobehavior. But we are talking in general about poor neurodevelopment outcome in IUGR. But the language is one of the areas that are more affected in this population, because near 30% of small babies will have language deficits. And it's really public health concern, because we know that it's associated with school failure, social, emotional, behavioral problems, and finally, in poor employment outcomes. And in this point is when our group, with Lola Gomez and Carlos Estera, studied how could we try to evaluate fetal programming for language acquisition impairment. In the fetus, we thought that maybe we could evaluate some image biomarkers that had relation with acquisition of the language, and in the newborn, the study of the frequency following response. Maybe if we can detect those fetuses or newborns that will present these problems, we can apply some strategies to improve the outcome in this population, maybe from prenatal life, we don't know. The first step to have a correct acquisition of language is to have an integrity of the auditory system, of course. And how can we evaluate it? The newborn cannot answer us. We cannot question something and the baby will answer us. So how can we know that it's hearing us? Then we have the evocated auditory potentials. The most famous auditory potential is the auditory brainstem response, that it's working with a stimulus, that it's a click. And then if we find a normal 5 wave, we know that the newborn is hearing correctly or is hearing the sound. So it's useful to assess the auditory pathway integrity. And this is the technique that we use for the universal screening of congenital deafness. When a baby is born in a public hospital in Spain, all of them will have this auditory brainstem response before going home to know if maybe there can be a congenital deafness. But the next step of these evocated auditory potentials is the frequency following response. Here we are not only evaluating the click. Here the stimulus is a syllable, like for example, da, with a consonant and a vowel. And this is useful to evaluate language disorders. And this is what we try to deep study in newborns. The first study was from Teresa Rivas, that she evaluated the viability to perform frequency following response in newborns. Is it possible? A baby that maybe is crying, I don't know, how will we perform this technique? Then it's possible in spontaneous sleep. And she comproved and she published the first normograms in normal population. And in parallel, we tried to think what brain structures could have most important role in the language acquisition, and how could we evaluate it by neurosonography. And we choose these 2 measurements, that is the tactile length. The tactile length is a structure that contains the inferior colliculi, that it's a very important nucleus in all these functions. And through the use of the corpus callosum fastigian length, we could evaluate the midbrain that contains nucleus that have always important role in the acquisition of the language. And we designed this study. This is a study from Diana and Teresa. We selected fetuses with low birth, and all of them had a prenatal neurosonography evaluating brain structures. And the first is that we found that small fetuses had smaller corpus callosum fastigial length, so an impairment in the midbrain growth, and smaller tactile length. I will specify that because maybe sometimes people think, oh, okay, it's normal, the babies are smaller, so these structures are smaller. If the head is smaller, these structures will be smaller. We always adjust all our results for confounding factors as gestational age, as brain size, as head size, all the factors that we can think that can confound the results. And instead, adjusting for all these structures continue being smaller than in controls. And again, of course, we are talking about corpus callosum. The corpus callosum was again smaller in the posterior part. That is the part that we know that connects the cortex, the temporal cortex, that is the one that has protagonism in the acquisition of language. And when we studied the results in the frequency following response, we observe an alteration in the sound encoding. Later, there are some flash talks that can resolve lots of doubts about this because they are completely experts. But in general, you see that fetuses that were smaller had an alteration in the sound encoding and maybe could have some relation with the alterations in the white matter maturation that we said that have those babies that maintain chronic hypoxia. And in the contrary, we always think that maybe to be born very big, it's like very good. But no, because most of these babies are born from diabetic mothers that maybe are not diagnosed during the pregnancy, but really there was an alteration in the metabolism of the glucose during the pregnancy. And when we studied again the frequency following response, we found that this also had alteration in the sound encoding and even more severe than in intrauterine growth restriction. And this, just to finish, it's interesting because this study compared the acquisition, the frequency following response answer depending on the prenatal exposure to music. So if the mom sang, put a lot of music, stimulated the baby with music during the pregnancy, these babies had a much more robust sound coding. It's very important because maybe this can open the window to prenatal stimulation to improve the results in the language acquisition. So for us, it can be an aspect to continue studying. So just to finish and to take home message, remember that non-severe neurodevelopment abnormalities have subtle changes in brain structures. The neurosonography is a very useful tool to detect prenatal brain biomarkers of neurodevelopment. And the corpus callosum, of course, corpus callosum assessment is an accessible biomarker of fetal brain connections and white matter. And reductions in this structure could detect fetuses with future abnormalities. The neonatal frequency following response is sensitive to fetal risk conditions, so babies born with fetal growth restriction and large for gestational age have compromised results in this test. And the neonatal frequency following response is sensitive to sound exposure during pregnancy. So it can increase the neuroplasticity even before birth and opens the door to sound exposure intervention to mitigate language acquisition risks. Thank you very much, and thanks to all the team that hard works daily in this research. Thank you.
Thanks, Míriam, for this nice talk. Before questions, just a short remember. So there's people that is attending the meeting by streaming. So the ones that are in streaming, if you want to just make a question, just write the question on the chat, and I will just read this question for you. Okay, so time for questions. Okay, so we have first question.
Hi, very nice talk. So my question is about the resolution of other structures other than the corpus callosum. Which is the variation or the percentage of variation that you can detect using sonography? And the second one, I have two questions, I'm sorry. And the second one is about the stimulation of brain circuitry. Do you think that you can act when the fetuses are still under development to potentiate the one pathway or another? Thank you.
The first question, oh yes, and it depends on the structure that we want to evaluate in the prenatal brain. We can have, maybe the variability can be more or less important. The corpus callosum is a feasible marker because the reproducibility is very high. And what we try to do always when we are measuring is that we measure twice and we always present the median of the results. But the truth is that when we compare between colleagues, and we have already published it, is a feasible biomarker in this way. But of course, it's important to acquire the correct plane for the image. We have very clear landmarks, and if we don't follow the landmarks, maybe, of course, the results are not comparable. But if not, yes, it's very good. And better than in MRI, for example, in our experience. Yeah. And yes, our objective is this, is by one hand to detect babies that will present problems, but of course, if one day we can detect them before birth and we can start some strategies, it's what we wish. Nowadays, we have different projects working on, for example, but it's more to maybe to try to change some habits in moms to improve the brain development more than when we find an alteration in the brain to be able to have an action in its development. For example, all the habits like the diet that the mom are following, we have evidence about the Mediterranean diet increases the results because our babies that at born term, less prematurity, birth weight, and so, in consequence, better neurodevelopment. No? Or for example, in a specific population, as IUGR, we are trying to supplement with omega-3s in high proportions, maybe to see if this can have an impact finally, and we can try to reverse. Yeah. But the plasticity after birth is still high, so maybe there we can also have an action.
Is this a lower corpus callosum length associated to associated to a...
Can you start, please? Because
yes.
I was not seeing.
Is this a lower corpus callosum length associated to a decrease in the overall myelination in general in the brain, and that's why...
In what? Sorry?
In the overall myelination of the brain?
Yeah, it's our hypothesis. The truth is that the corpus callosum are the fibers that are crossing, and it depends on the myelinization of the white matter that happens at third trimester. It's a moment when we are evaluating these babies. We think that there is an impairment in the white matter maturation because of alteration in the oligodendrocytes, and it's reflected in the size of the corpus callosum.
Hi, thanks for your talk and for the job that you do at the hospital. And my question is most a curiosity about neurosonography. As you said at the beginning, there is an increased number of detection of behavioral disorders in babies, and most of the time these are not associated to some problems during, detective about weight or problem in the mother. My question is if there are some parameters that could be checked to assess if there is some behavioral disorder in baby prenatally, or if we have always to wait postnatally phase to see interaction of babies and how they interact with the society, the world. Thank you.
Thank you for your question. At the moment, we don't have any functional proof in fetal life to see what's the answer to stimulus or no, just image. It's the only thing that we have, by the way. So No, now what we are trying to do is we have a FIS study that we are going to start that what we are going to do is to have normal population and to measure lots of these structures that we consider that can have a role in the growth of the brain. And all these babies will have a follow-up, a neurodevelopment control at 2 years, and in the future, if we can continue with the cohort, later on life. No, and this is what we want, to have normal population and to see, okay, the corpus callosum is shorter than expected. What's the meaning of this? Because it's okay, I know congenital heart defect, have neurodevelopment disorders, are UGR, but in a theoretically normal pregnancies, what's the meaning of these structures? Because, for example, sometimes there are studies that say that it has a relation with autism, you know, but theoretically, we're normal pregnancies. So we cannot inform or to say anything to the patients because this will not be relevant information a part of the managers she will have of the information during the pregnancy. Yeah. Thank you.
We have time for a really short question, if there's any in the audience. Okay. So, if really are short questions, okay.
Thank you for your talk. Was the language deficit a delayed acquisition of language or a deficit in some specific language domain?
No, it's in general language acquisition, not in specific areas. No. Now, no. Maybe in the future we'll have information for all the areas.
Okay, so thank you so much.
Thank you.
We move to the next talk. Okay, so the next talk, so will be given by Sandra Acosta. Dr. Sandra Acosta is assistant professor at the Department of Pathology and Experimental Therapeutics in the Institut and the University of Barcelona, and she's a developmental neurologist interested in undertaking how the human brain features arise during evolution and its implication in neurological disorders. So today she's going to talk about brain organoid models of neurodevelopment disorders powered up by deep learning. So thank you so much, Sandra, to be here. So your time.
Thank you, Silvia, and thank you all of you for being here and to the committee for selecting and inviting us to give this talk. As you said, today we are going to explain one of the lines of research that we have in the lab and that we are focusing on applying different tools to explore and model neurodevelopmental disorders. And the first thing that I want to introduce to you are brain organoids. I'm pretty sure that you've been hearing recently about brain organoids. There's been quite a fuss in the news about them. But just very briefly, organoids are these 3D structures. I'm going to start this panel in the middle. So they are big cellular structures that grow in 3 dimensions. That means that they recapitulate the cytoarchitecture that parts of the brain can have. But one of the advantages, or one of the major advantages that these brain organoids have is that they can be developed from cells that derive from patients. And that opens a new horizon for exploring developmental disorders that have not found a right model in other kind of species like mouse models or even people exploring with invertebrates how neurodevelopmental disorders happens. And the hope that has been put on the table about a decade ago right now is that since we are coming from a cell that has a genome, and actually these cells are extremely undifferentiated, mimicking what is happening in the most earliest stages of human embryogenesis in the blastocyst, these embryonic stem cells, we can push them to follow the developmental path that a normal cell in an embryo will have, and then reach this neuroectoderm that we've heard before, that will eventually develop all the kind of cells that populate our brain from a neural origin. And then since we have a three-dimensional structure, these cells are organized in a way that they communicate to each other very similarly to what will be happening in the brain, right? So we can study many different aspects that otherwise we won't be finding in other kind of models. Like, for instance, initially that was thrown for a model for brain development in general, but little by little in these last 10 years, these models have been ranged into a wide range again of developmental disorders, but not only developmental, also neurodegenerative disorders. So how does an organoid look like? So this is a picture from an organoid grown in our lab that you can see three-dimensionally with a marker that we will discuss in a second, labeling the neurons on the surface of these organoids. But if we will make a section, what we will find is that, as I told you, this is happening following the same cues, the same milestones that we will find in a developmental brain. So meaning that we have to start with the progenitors, the progenitors, and these progenitors will be giving rise in a wavy form, as it will happen in the human brain, to the different neurons that populate, and in this case, this is a cortical organoid, so we have this multi-layer aspect that we find in a human brain, and in between we also find astrocytes and eventually other kind of neural cells. So how do we reach to this point? So we start by this is H9, this is human embryonic stem cells, but the same will be happening from iPS derived from patients. So first of all, we need to grow them in a way that we call embryoid bodies. So this is like the very similar way as the blastocyst. And then we push for the neural induction. So we tell those cells that still are pluripotent to reach the neuroectodermal pathways that will lead to the formation eventually of neurons. And that happens during around a week, when they are at day 22 of differentiation, more or less. Then we put the signaling that those neuroectodermal cells, very primordial progenitor cells, to reach the point in which they will give rise to the first neural progenitors and eventually the first neurons. And that happens very early, in the first 30 days. But then these organoids keep on producing different germinal cells, germinal structures. They are highly variable. One of the things that, if you notice in the previous slide, and I'm going to go back, they have these very separated structures. Those are the germinal centers. These are rosettes of progenitors, and each of these rosettes is going to differentiate independently one to each other, although the neurons eventually will connect, but they will not be connecting as it would be happening in the brain, because each of these structures will have a different identity. So, and this is something that so far we cannot control. So I'm not going to lie to you, these are one of the downs that the whole system has, but this also can become, and this is part of what we're trying to do, an advantage, because we have, metaphorically, don't take it as like a real world, as a truth, but we have multiple brains inside a single organoid. So we can explore that high variability that we have in our advantage to learn and increase the numbers of our quantitative analysis. So if we will continue our differentiation, we will reach a point in which we have plenty of mature neurons, but we still have, and this is very different of what is happening in the brain, we will still have a lot of cells that are generating different neurons. So we have to balance on what we want to analyze. But if you look at here in the different stainings, as I said, we have progenitors, Mark-Minestin, we have newborn neurons, and then also at the very same stage, we already have astrocytes. So this is different of what we will be finding in the brain. And this is problematic, because if we want to study, for instance, the consequence of a neurodevelopmental disorders, that indeed, as we just heard in the previous talk, many of these neurodevelopmental disorders, they can rise in the very early developmental stages, but actually the pathology, we find it at later stages. So we had to find a way to have a good readout of how these neurons are looking like in our cultures, right? So one of the first things that, in the last 10 years that we've been doing organoids in the field, and some of us that jump into the organoid field from very early stage, so we were doing classical staining, so sectioning, putting our markers, making sure, like, common ground for territory for all of us. But I just told you before that each of these single little brains that are inside an organoid, they connect to each other in a different manner. And all these, like, axons that you actually can clearly be seen here, they connect randomly to the different areas. But is this good or bad? Can we see it? Can we measure? Is this useful? Is this like actually a flaw of the whole system? So the first thing that we could see was like, well, let's try to map how this is happening in our organoid. So we use this staining, and this is a live staining. We put a dye, and we let the organoids grow. We label these axons, and then we measure what's happening. And with that, we like directly jump into, is this, so because if we have a normal system, we cannot evaluate if it's normal or not, actually, because we know that this is a complete different system, an organoid of what is a brain. It's just a model. So we go and jump into our interest, or the interest that I always have had, into analyzing and understanding how neurodevelopmental disorder happens. But the kind of neurodevelopmental disorders that I'm most interested in is seeing those problems that happen and arise from early fetal stages, but actually can degenerate. So for instance, epilepsies. Epilepsies are neurodegenerative processes that some of them are genetic. That means that they are coded in the genes, and this is right before the birth, in the very early stages of the formation of the brain. There are some phenotypes at the cellular level that can be observed, but not at the developmental level. And that's the case for Dravet syndrome, the kind of disorders that we're using in the lab to prove as a proof of concept. So this is a very severe kind of epilepsy. It's actually an epileptic encephalopathy that is driven by mutations in the sodium channel 1A gene. So this code, as I said, for a sodium channel, that it's mainly expressed in interneurons, and then the brake that the glutamatergic neurons need to control the electric impulses is failing. So these kids have a drastic consequence throughout the first years of their life, but they are not diagnosed until they are about 6 months to 1 year of lives. So how those organoids look like? So far, all of this is unpublished data, is submitted. We have organoids that are very similar. So DS stands for Dravet syndrome. So we have control cells. This is Dravet syndrome at 35 days of differentiation, and then if we let them grow for like a few more weeks, 90 of differentiation, we start seeing differences in a section. So this is the length, the extension of all these axonal layer that it's in the outer range of the organoid in a control and in a Dravet syndrome. So as you can see, this is way longer, way thicker than what we can detect in the control organoids. But at the end of the day, those organoids are populated by very similar kind of cells. So we have progenitors, we have early-born neurons, we have mature neurons, and as you can see, the only change that we could detect by quantifying with the conventional tools like sectioning, as I just told you, is that the proportion of mature neurons, it's a little bit higher in the Dravet syndrome than in the control cells, but all the rest of cellular components are the same. So how are we going to model something if we can actually not see what is happening? So that's why we think that artificial intelligence can give us a hand. So one of the problems when we are doing this section is that we just sing from a little hole, and we pretend to extend this result for the rest of the organoid. But I insist again that these organoids are heterochronic, and they are very variable inside of it. And this is a picture showing how different organoids from a control iPS cell line look like. So they are extremely variable. Is this good? Is this bad? We don't know yet. So far, this high variability has been labeled with a bad thing for the organoids, one of the flaws, where we're trying to see if it's really something that we can overcome or not. And to do that, we are intending to use artificial intelligence. So this is brilliant work by Isabel and Adriana, somewhere here in the audience. And they have acquired pitches or lab organoids, and they have implemented this deep learning, because it's actually deep learning, it's artificial intelligence boosted, multi-step protocol. And what we have just seen, now here they are, the picture I thought it was before. We have, first of all, compared if the different differentiation, each batch of organoids can be considered as the same, or actually the differences between the batches was something that was a flaw or something impairing the analysis. So what we can see here is that we have two differentiations. I hope you can see with the contrast here. It's a little better. So the two batches fall apart. They fall very different in the size. And what you can also see is this worm-like structure that actually those are the different pitches in a Z-stack of the organoids put together. So the first thing that the artificial intelligence system does is recognizing all the pitches of the different organoids as a whole. And the second thing is that, yes, it detects the variability from the different batches. And what happens if we put the defective of the mutated organoids into the whole system? So what it happens is that still, although we could detect variability in between the different batches of the control, the Dravet already have some intrinsic differences that are enough for the artificial intelligence to accurately, like around 90% of accuracy, to detect that actually it has a disease. So that was very good. I was actually very happy, but obviously, and we just saw in the first session in the morning, sometimes we want to go a little bit further with our research, right? We want to translate it into society. So organoids have been proposed for a while as a drug testing tool. So this is what we are trying to do now. So the first thing that we have been doing is using two drugs. One that we know that is the first line drug for many epilepsies, valproic acid, and is actually useful for some cases of Dravet syndrome, and phenytoin, that it is an agonist of the sodium channel, so it's toxic for Dravet. And what we see in a normal hematoxylin neoacin is that actually these drugs, the phenytoin, is toxic and generates cell death. And we can see from our artificial intelligence system is that indeed what the organoids, the Dravet organoids that are treated with valproic acid, so the one that is useful for the treatment, they are moving a little bit closer to what it will be classified as a control cell line, while the phenytoin, they don't. And if we look one organoid at a time, we see the difference here. So this is the pre-treatment in blue organoids, and then we see that the prediction towards a control level, it's improving for the valproic acid treatment for all the organoids, but not for all the organoids that have been treated with phenytoin. That actually remains low with some exceptions. So there's lots of improvement in the whole system, but we think we are getting to that. So we are now treating with different kind of anti-epileptic drugs, and we are seeing that indeed there are some movements on how the organoids behave upon the treatments, and we hope we can summarize this work in a publication in the next few months. So summarizing what I just told you is that we have these three-dimensional structures called organoids that actually have been proposed for modeling for many things. They initially started for disease modeling, and like very slowly they are moving towards different and more sophisticated analysis like electrophysiology, but also life imaging and behavioral imaging in those organoids. And indeed, they can be used, or they are starting. There are not only our lab, many other labs are doing it, as a tool for drug testing. And eventually, the fact that they can come from IPS derived from patients, people is proposing, and we like this idea, to be used as personalized therapeutics in many of the different aspects that generating a cell in a controlled system in vitro can be applied as a therapy. And with that, I want to finish. I want to thank my wonderful team. It's been a nice adventure in the last couple of years, and we are growing, and we are seeing the last results, as you can see here. and also our awesome collaborators and our awesome funders that actually sustain our work. Thank you very much. Thank you.
Okay, so time for questions. We have one here.
Very interesting, very nice. I actually think it's brilliant that you're turning this weakness or criticism of organoid as a technology in that it's so variable from one organoid to another. You're using it as a strength to see whether you can use that inherent variability as some kind of meaningful outcome. I think that's very clever. I just have a simple question. In the syndrome organoids that you were developing, just in general, are they more or less variable than control organoids?
I don't think I can conclude in a quantitative way, but overall they behave very similar. So it took us a very long time to discriminate by yourself if it was behaving different. So in principle, they behave similar. So the shape, the growth are the same. They have very similar kind of like roughness in the surface. So by with the normal tools that we're using in live microscopy, we cannot determine if they are less variable. So in principle, that will answer. Having said that, it's not a quantitative, it's an impression, very similar to what the controls will be doing.
And I think you answered my second question, is it's mainly morphological characteristics that you're looking at.
Partly yes, partly not. So if you mean morphology, yes, it's certainly morphology because we are doing microscopy without using any specific markers. So it's just how the cells are composing the whole organoid, but they are not like the classical things that we will be using. So it's not the size. Size is irrelevant from a good organoid. We have to see that this is a variable system, and sometimes we need to discard some of the organoids because they don't progress properly. So we need to discard those that are not properly advancing. But on those that we consider they are healthy organoids, healthy in terms of differentiation, but not in disease. So like, it's a good model to say. So those organoids that recapitulate what we want to see, those are actually similar size, and size is not the most important. There are other variables that we are exploring with our artificial intelligence to see what is picking this system.
Thank you.
Okay, so time for one more question.
Thank you very much for the talk. Do you have activity data to see if activity data, I mean, for instance, spontaneous activity, to see whether the structural alterations that you see correlate somehow with functional deficits?
Not yet. So we know that we can detect calcium signaling. So Andrea is in the audience, and the row behind you is trying to put it into place, calcium signaling in live imaging in the whole three-dimensional structure to see if this is working or not. But we don't know yet if we recapitulate the deficits of the Dravet syndrome into the spontaneous activity.
Sorry, yeah, but for instance, do you have any prediction, for instance, that the organoid is more synchronous upon disease or no? Okay, thanks.
Zero data on that yet. Thank you.
Okay, so if it's a short question, Clelia, okay, and a short answer, please.
Yes.
Okay, thank you, very shortly. My question is, since there is a lot of variability and I mean there are lots of reviews that demonstrate that when you use IPS or embryonic, you can have completely opposite phenotypes in the disease model. If you have used both IPS and embryonic provided to the model to, I mean, if the model also is able to discriminate this alteration between...
So you mean if we can model the variability intrinsically driven by being an IPS or an human embryonic stem cell?
Yeah, if I mean, in this publication that you are submitting and you have to publish, if you have demonstrated this with embryonic and IPS as like an intrinsic factor of read the variability of stem cells?
So as control Dravet, they are iPS cells, so we don't have an isogenic human embryonic stem cell of them, but to short answer is yes, we have controlled iPS and human embryonic stem cells, and they behave more similar to them than to the Dravet. So for the artificial intelligence system having, yeah.
Thank you.
Okay, thank you.
Okay, so we move on. The next speaker is Dr. Josep Maria Canals. He's currently the director of CREATIO, the Production and Validation Center for Advanced Therapies of the University of Barcelona, and he's also associate professor at the Department of Biomedical Science here at the Faculty of Medicine. His research lab of stem cells and regeneration medicine at this department has focused on the use of stem cells as a therapy for neurodegenerative diseases. Today, he's going to talk about in silico and in vitro modeling of human neurodegeneration. Thank you.
Okay, thank you very much, Silvia. So first of all, I want to thank the organizers for inviting me and giving the opportunity to explain our results that we had in the last 10 years. So I will do an overview of the different models that we have generated in the lab, and our focus is to study human neurodegeneration, because as you know, most of the clinical trials fails when you move from mouse models to human beings, because the system is different. And I'm trying to convince you, in fact, I hope that I convince you at the end of this talk that we can use in silico and in vitro models to study the human neurodegeneration better than using an animal model. So today I will talk about these topics. So first of all, I will show you how we establish an in vitro protocol to model striatal neurodevelopment. And then we are going to move to modeling HD in vitro and in silico using IPS and machine learning. And finally, we are going to move to our last results that are still unpublished data on brain-on-chip systems to study brain connectivity in vitro. So let's go to start for the first topic. And to study the first topic, we have to try to reproduce one system in the dish. So our focus of interest is the striatum. As you may know, that the striatum is one of the main areas of the brain that control the movements, and it's composed by different subpopulations of neurons. There are two subpopulations of neurons that project outside of the striatum that we are going to call neuron projecting neurons, or MSNs, and they are GABAergic that express DARPER32, and they express either enkephalin or substance P. And then we have a small family of interneurons that can be subdivided in different cell types. And in Huntington disease, we know that there is a monogenic disorder that has a mutation in the exon 1 of the IT15 gene in humans, and this mutation leads to a repeat of CAGs in this exon. And we know that when the patient has more than 37 repeats, they will show the disease later or early in the disease, depending on the number of repeats they have. Okay, and this produces a neurodegeneration of the MSNs, of the medium spiny neurons in the striatum, and a drastic reduction in the caudate and putamen volume and enlargement of the ventricles. So that we want to do is to try to reproduce the striatum, how the striatum is developed, to analyze how the Huntington can affect this development. And to better understand that, you need to know that the MSNs, the medium spiny neurons, start developing from the neuroectodermal progenitors. Then they differentiate into encephalic progenitors. This will generate neuroblasts that migrate to the mantle zone, and finally these neuroblasts will be differentiated in medium spiny neurons. So some years ago, Monica Pardo, a PhD student in my lab, did a microarray study making laser capture of these two areas that you have here, so the area of the germinal zone and the area of the mantle zone, and she was interested in studying changes during the development of these different areas. And you can see here that she did studies at E12, E14, E16, and E18 using mouse models. And she generated a lot of data sets that we use to compare with human pluripotent stem cells and to develop a model of Huntington's disease. But the main goal was to analyze the profile of gene expression during development. And using this profile, Marco Straccia, another postdoc in my lab, a past postdoc in my lab that I think that is here in the audience, he took this information and he designed a high throughput platform that is called OpenArray that we can assay 2,700 PCRs at the same time using a chip. And he developed this kind of, this kind of platform, putting different genes that we can pattern the differentiation, and we can compare with the embryonic human development. And in fact, in collaboration with Anne Rosser in Cardiff University, we compare a different kind of stem cell differentiations with human fetuses, with the material coming from human fetuses using this platform. And as you can see, we can compare with the double GE, that is the caudate putamen during development, and we can correlate our stem cell differentiation with this line that is the standard line, that is the real human development. And we can say we are close to the human development or we are far away from this development. So the microarray information also gives us a lot of information about the mouse development, and we thought that we can use this information to generate a protocol to differentiate human pluripotent stem cells in vitro. So in collaboration with the Nick Allen group, here you have at Cardiff University, Andrea Comella, also a PhD student in my lab, developed a protocol that goes from embryonic stem cells and induced pluripotent stem cells to medium spiny neurons, reproducing the same steps that we have in mouse development. So she did a protocol that first we obtained neuroectodermal progenitors, then we obtained telencephalic progenitors, neuroblasts, and MSNs. Okay? She characterized this protocol, and just to make a long story very short, I show you some peaks. We know that at day 16, we have telencephalic progenitors, as you can see here, using the OpenArray platform. We can see a lot of genes expressed that are typically expressed during striatal development. Okay, and you can see here that we have, for example, expression of EBF, that is a progenitor of the direct pathway in the striatum, that is the substance P expressing cells. And here we have DLX that are expressed by the indirect pathway. So after 37 days, we have fully mature neurons, and as you can see here, and these neurons express markers of medium spiny neurons like DART32 and CTIP. Finally, in collaboration with Jordi Soriano's group, we analyzed the activity of these neurons in vitro, and we show that they have spontaneous activity. In fact, around 80% of the neurons that we generated in vitro, they demonstrated spontaneous activity at different levels. There are some groups that show a high activity, and there are some groups that show a very low firing activity, as you can see here. So using this protocol, now we are interested in moving to modeling Huntington disease in vitro and in silico. So we start to do single-cell analysis of these progenitors that we have between day 12 and day 16 during our differentiation protocol. And Phil Sanders, a postdoc, past postdoc in my lab, did a lot of single-cell studies using different embryonic stem cells and induced pluripotent stem cells, cell lines coming from controls and also from HD carriers of as models. Okay, and he was working in collaboration with the technicians in the lab to obtain the samples from 3 HD related cells and 3 control-related cells. And he did single-cell analysis in collaboration with the Holger Heinz group at the SYNAC. And we analyzed all the results of this single cell. This is still unpublished data. So we demonstrated that we can generate both progenitors. Progenitors that give rise to EBF-positive cells, that, if you remember, these labels the progenitors of the direct pathway, and progenitors of the DLX5 positive cells that generate the indirect pathway in vitro. So we are convinced that we can follow the maturation of these progenitors in vitro, and we can define which clusters belong to MPCs or to neuroblasts. And in addition, we can compare both cell types. So we can compare control and HD-derived pluripotent stem cells, and you can see that they seem to follow different trajectories during striatal development in vitro. So, in collaboration with Petty Arredeva, Wasim was working on the in silico modeling, and the idea was to, first of all, to establish a pseudotime that can give us how the different clusters that we observe in vitro can correlate each other using a mathematical model and machine learning. So he developed this model in which we have the progenitors here, then we have the neuroblast, and you can see that they differentiate or they follow two different trajectories. And using this mathematical model, he developed a system to analyze the trajectories and to analyze the high variable genes, and using the analysis of the high variable genes and these mathematical trajectories, he can also ask about how many genes we need to revert to move the HD trajectory into a control trajectory. So the idea is that using this system, we can analyze how many genes we need to change during development to revert the HD phenotype, and which are these genes. And this is much more easy than going gene by gene in vitro, as you can imagine, doing genetic modifications, because this is a mathematical model and you can start just modifying 500 of genes or whatever. No? So this is a very powerful model, and we think, and we are still working on that, improving this model now with Petia's group. And finally, I want to show you our brain-on-chip system that Clelia developed in the last period of time. And this was in the context of one European training network, Clelia Introna in my lab, in collaboration with Ines Pereira, that was another student at the Samitius group, and also in collaboration with Tornero's group in our department as well. We developed this system. It's a brain-on-chip system in which we can see different cell types, and we can differentiate them in vitro at the same time or at times that are depending on what we are interested. So the idea is that we can see cells here in the yellow chamber in the middle. We can see cells here in this upper chamber, or we can see cells here in this other chamber. And as you can see here, we can observe the seeded cells inside this area, that is the area in which we are going to analyze the results. Okay? And using this model, we can seed cells from our differentiation protocol and other protocols, and Clelia has done that. And you can see here the inner part of this brain-on-chip system, and you can see here that we have seeded cortical cells using the protocol that had developed and Dani Tornero, and our protocol of MSNs, and we have the MSNs here, and we have the cortical cells here, and you can see how the cortical cells connect to the striatal cells. And we observe that when we stimulate with potassium chloride the cortical cells, some seconds later, we see the response in the striatal cells in vitro. So now we think that with this model, we can study the connectivity, and we are going to start seeding cells derived from Huntington disease in this model. And in addition, using this model, we can also analyze the development and how the influences of the afferences affect the development of striatal cells. And as you can see here, we have done that, and here we have different models. So here we have striatal in the middle and cortical at the periphery. Here we have striatum and empty space, and then we have striatum and striatum to compare. And you can see here that when we put cortical cells in the upper and lower chambers, we have an increase in the markers that are characteristics of Huntington disease. And in addition, if we analyze the activity of these cells in the striatal cells, you can see that using cortical projections, we increase the activity of the striatal cells in that chamber. So with all these models, now we have set up a platform that is called AvantDrug, that is for neurotoxicology and drug screening, and we have really good quality controls. We work with ISO, and we have also GLP procedures, and we are a technical platform recognized by the Generalitat of Catalonia. And if you are interested, here you have the web page, and you can check the services that we offer. And I finish here just thanking my group, that is the most important part of this work, and also thanking our collaborators that I have been mentioned during the talk, but also the founders. And most of the work that I show here was supported by the CHDI Foundation, that is an American foundation, La Caixa Research, and also for European grants from Marie Curie actions. And thank you very much, and I will take questions.
Okay, so thank you for this talk. We have one question here.
Very impressive, thank you for that. I'm particularly interested and excited about your different platforms. I'd love to talk later. I guess my main question to ask for comment is related to this variability issue. I'm more familiar in the cell therapy space as opposed to disease modeling. And there we know that both mainly for iPS cells, the different lines of iPS cells are highly biased to one lineage or another from the beginning, and that seems to be more from the source tissue, so from the somatic origins. And it's even worse that it's not just the individual lineages, but the individual clones that you choose right at the beginning can affect your outcome. So I'm just wondering about your views on that.
Yeah, that's true. We have a huge variation. We have some variation when we compare embryonic stem cells versus iPS cells. So the gene expression profile is completely different. But when we compare intrinsic induced pluripotent stem cells or embryonic stem cells, if we compare both models, embryonic stem cells are more stable than induced pluripotent stem cells. We think that the reprogramming procedure is something that increases the variability of the samples. But of course, we have examined many different cell lines in the last years, and it's important first to analyze the quality of the cells that you are working with, because most of the cells has karyotype abnormalities, or they develop in vitro. And we just published a paper showing all the analysis that we have done in the last 5 years. And second, you have to test if this cell line is useful in your protocol. As you said, not all the cell lines are useful using a standard protocol. But we have reproduced this protocol more than 500 times at least in 10 different cell lines, and the results are quite robust.
Okay, so more questions? So meanwhile, I have a question. So following Sandra's talk, working with these brain organoids, so my question is, okay, what's the benefit of the drawbacks of using the brain organoid versus these IPS?
Okay, so I would say that I am not quite positive with brain organoids. Because I think that Sandra did a very intelligent approach or using the variability of organoids to study that. But usually when you read the papers, you see the fantastic picture of the organoids in the article. And I had a student working for more than 1 year on brain organoids, and of course you get this picture, but 1 out of 50. So you have to do a lot of differentiations and a lot of organoids to get that. Instead of that, we are moving to another approach that is getting mini brains or brain organoids using 4D bioprinting. And we have just started an European project with different partners in Europe that we are going to develop mini brains using 4D bioprinting, using laser-assisted 4D bioprinting, and we think that with this model we are going to reduce the variability because we can seed the cells in the right place at the right moment. And this is our approach.
Okay, I don't know if Sandra, you want to say just a short comment on that?
Thank you. I totally agree. I mean, there are different approaches. Each of us is using the same. And I'm going to put on the devil's side now, of course, right? I'm a strongly defender of organoids. And the main reason is because they are unguided, or they are slightly guided. That means that the kind of progenitors that we can have, they are much more variable, but it has the advantages. So, for instance, Alzheimer's has not been able to be modeled very in depth. One of the main reasons is because we have like an organoid that is differentiating at the same time that it's mature. So we need to know where to look. We need to know how to look at those things, and this is what we are trying to implement. Having said that, I don't mean that modifying or getting progenitors and putting bioprinting progenitors. I mean, and I'm sure that all of us doing for a long time culturing progenitors and culturing neurons, we know how sensitive they are to any kind of manipulation, especially when they are at single cells. So for me, I was when bioprinting came up, I was looking at it very excited. I always said that there's a new technology, I want to jump on it directly, but I thought, well, I mean, we're going to affect the physiology of those neurons. So this might be one way, but probably it's not the unique. So that's my taking home message on here. I'm still defending my organoid, certainly.
No, I would like to add something. So I think that models are models, and all models are useful. Mouse models are useful for something, in vitro models are useful for other things, brain chip is another system, and organoids are another system. So combination of all of them, I think that will give rise us to therapeutic approaches for neurodegenerative disorders. At least I expect that.
Totally endorse that. So
I think that we keep with this message now, meaning that model as a model, and so we can use as all the models that we have to just prove different things. Okay, so thank you, all of you. Okay,
Thank you.